I would request Dr. S.K. Poddar to come here and to introduce our honorable chairperson and to take the CME forward.
Thank you, Dr. Chauhan. Today's topic is very pertinent, bariatric and metabolic surgery in 2017. Because bariatric surgery is now very popular, and it's not only weight loss surgery, it's called metabolic surgery because, as Dr. Wadhawan will tell, it's metabolic surgery because it cures many metabolic diseases. So we are fortunate to have Dr. Randeep Wadhawan as speaker today. He is director and head of the department of minimal access, bariatric, GI surgery and robotic surgery at FORTIS Hospital, Basantpur. He is executive council member of Obesity and Metabolic Surgery Society of India. He is vice president of Hernia Society of India. He is visiting professor of the INCAR, Taiwan. He has published more than 30 papers in various journals, and he has taken more than 200 guest lectures at national and international conferences. Please give a big hand. And he is also operating faculty in more than 30 workshops for bariatric and advanced GI procedures done in various parts of the country. I welcome Dr. Randeep Wadhawan, and I request you to give him a big hand. Dr. Randeep Wadhawan.
Thank you so much for the introduction, Dr. Poddar. It's great to be here and great to have so much of audience, because invariably when you go for the CMEs, you find that the audience is thin, and that really puts off the speaker. But great to have so many people here, and particularly on a Wednesday. And I actually congratulate the physician forum that you all have continued, and you have all continued to have these CMEs and given opportunities to various people to give their point of view and hear them out. So thank you so much for that. I bring greetings from Fortis Hospital, Basantpur. I'm also attached with the Fortis Escorts as well as the Fortis Sea Dog, which is just 2 buildings away. And I do most of my procedures are done at the Fortis Basantpur, and that's my team. And like they always say that you're only as good as your team, so I thank my team for all the work that we are doing today. We are a center of excellence. That's important, because what is important is if you're a center of excellence, that means you're maintaining certain standards of care and certain SOPs which are required to ensure that the results are the best. And we ensure that by being a center of excellence for metabolic and bariatric surgery. We are also a center of excellence for Hernia Society of India, and we keep conducting these workshops regularly. So you would have heard, some of you would have heard my lectures already and previously as well. And so I was just wondering what I should be presenting. So I said, let's look at where we are in 2017, and even the 3 short videos that I intend showing are, you would probably not have seen those videos before. The idea is what we have progressed from when we started doing bariatric about 10 years back to where we are now, and how we have progressed over these 10 years, and what we are doing as of today. We already know that we are in the middle of a global pandemic, which is obesity, and India is no different. We are actually ranking 3rd worldwide as far as the number of obese go, almost 40 million obese. We can go up to 50 or maybe beyond by 2030, and even we have in rural areas a lot of obese. So obesity is a pandemic which is there, and we also know that diabetes, which you all would be treating various times in your life, and regularly in fact with your patients, that type 2 diabetes is increasing, and we have 62 million as of 2013. Probably the figure is much more as of today, and if we go by these standards, by 2025 we'll probably be 85 million. So that's what's expected, and the average age of onset is 42.5 years. That's pretty early actually. There are certain myths. I actually saw these, and Dr. Mishra had these slides, and I kind of asked them for these slides, and they are very pertinent as of today. And So it's not just the adults which are affected, it's basically the children as well. And what we find is that, what all these diets that we have as of today with pizzas, burgers and so on, even the children, 25% as far as the urban population goes, the adolescents are actually obese or overweight. There are certain myths, and I thought we'll just go through all those myths, whether they are true or what is the reality as of today. Fat children are healthy. With age, baby fat will go away. That's the myth. But the reality is 50 to 70% of obese children will always remain as obese adults. That's the reality. So that's the myth and that's the reality. So it's not as if they lose all their fat, they'll continue to be obese if they are obese as children. The myth, what will happen if a child is fat? He or she will not have any disease. That's not true. Diabetes may set in early. Polycystic ovarian diseases, excessive facial hair in females, infertility may occur in girls. So that's the reality. Heart diseases start at old age, that we all know. But actually what happens is hardening of the blockage of the artery starts at about 11 years in boys, and 15 years in girls. That's where it starts. So that's the reality. So we can't move away from the reality. That's what's the truth. A fat child is otherwise healthy. That's not true. 20% of urban population have syndrome X. We know with dyslipidemia and hypertension and all those other problems and metabolic syndrome, and they are just a step away from diabetes and 2 steps away from heart diseases. Again a myth, a child does not develop high blood pressure or high cholesterol. That's not true. Many children will have high blood pressure and low good cholesterol, which is the LDL. A child should enjoy and eat and relax. Such time will not come again later. That's what the myth, that's what the parents would tell their children. But the reality is parents do not realize, but children are eating junk food all the time, and we've already seen the kind of junk food which is available and which they are taking. So actually they are not eating the right kind of food. Again a myth, all children are doing required physical activity. So what is recommended is 1 hour of, whether you do your computers or you do TV watching or whatever. That's not true. They do more than 2 hours every day. Time on TV, internet, studies leaves little time for play, and that's where the problem starts to happen. All of us, parents, teachers, teach them correct diet and lifestyle. Again, that's not true. Most do not have the correct knowledge and therefore do not give the correct, impart the correct knowledge. The last myth, so what if they are metabolic abnormalities or diseases? These can be easily treated. The reality, most of these diseases are catastrophic and have complications that cannot be reversed. So most will shorten the lifespan. So we look at the lifespan, we find that somebody who gets in obesity early may decrease their life by about 10 years, have obesity or type 2 diabetes later, may decrease it by 6 years. So that's something which is there. So these are all the myths and those are all the realities. So that's where the physicians come in, that's where we come in. Every time a patient walks in, do we advise a bariatric surgery? Do we advise a metabolic surgery? That's not true. They come to you first. You are the first people where these people do consult. Once they reach those BMIs beyond 25, you advise them lifestyle modification, and you also advise them pharmacotherapy. And if they do not, if they fail in these two, that's when the surgery is advised. So we come in much later. You are the ones who come in much earlier, and you are the ones who advise all this: a healthy lifestyle, a lifestyle modification, pharmacotherapy and surgery. So where we are today. So the topic today is that 2017, where are we as far as obesity, metabolic surgery, bariatric surgery. So this is an excellent paper which was published last year, and this was some of the best known people all across the world. So we look at the endorsed by all diabetic federations across the world. Almost every diabetic federation across the world has endorsed this paper. And this is something which is a landmark paper which was published last year. They're going to have another summit sometime next year. They have it every 2 years. And this was the paper and this was the algorithm which was actually published for type 2 diabetes. So when we talk about metabolic surgeries, that is the algorithm which is now recommended and followed all across the world. Patients with type 2 diabetes, if somebody is over 35-40 BMI, we recommend a metabolic surgery right away. But somebody who comes in with a much lesser BMI, what they've done is for the Asians, they've decreased it by 2.5 points and made it 27.5, considering that the Asians get diabetes or metabolic METs much earlier than the Caucasians, and therefore they've decreased it by 2.5 points. And they've said that even if you are more than 30, between this range of 30 to 35 BMI, which is a class 1 obesity, if they respond to medical treatment or your treatment, please continue with that with an adequate glycemic control. But if they have a poor glycemic control, they are already on OHAs, they require insulin, that's where you can consider a metabolic surgery. So even in this BMIs of 30 to 35, you can consider bariatric surgery for people who have inadequate control of inadequate glycemic control. But less than 30, non-surgical treatment is what is advised. There are some papers between 25 to 30 as well, but they are only as far as research protocol, not recommended. What is recommended is even going down to up to 30. Anyone over 35 in any case a bariatric or a metabolic surgery is actually recommended. This was something which was published much earlier in 2013. There's an Asian perspective to the International Diabetes Federation position statement on bariatric or metabolic surgery, and they said lower it by 2.5 points. And that was only because, like I mentioned, we get the METs much earlier than what the Caucasians do. And they said this BMI of 30 to 35, we can suggest a metabolic surgery, not responding or uncontrolled, not responding to medical treatment. The ASMBS, which is the American Society, is extremely strict. They are extremely clear about their guidelines. They've also got their guidelines down to 30 to 35. So they've said anyone between 30 to 35 can be considered for a metabolic surgery. So I've been talking about metabolic surgery. How is it different than a bariatric surgery? So we always call what is bariatric. Bariatric surgery means baros means weight. Surgery or the itricos or the bariatric, the itricos part means treatment of the weight. So surgery means treatment of weight. By surgery is bariatric surgery. So bariatric surgery comes in only more than 35, less than between that segment of 30 to 35, it's metabolic surgery. How is it different than bariatric surgery? The purpose of a bariatric surgery is only weight loss, while metabolic surgery is glycemic, metabolic control, cardiovascular risk surgery first done. And the answer is, sometimes they say 5 years, 10 years. The answer is 50 years. The first surgery was actually done in 1967. This is the father of, he's still alive. He's the father of bariatric surgery. He was doing a cancer of the stomach. He resected a part of the stomach and put a loop of intestine there, and the patient started to lose weight. And that's where the bariatric surgery actually came in. So it was 1967 where the first bariatric surgery was done by Dr. Edward Mason. So it's been there for 50 years. It's not like it's been there for just 10 years. So the results are there for that long. After that, metabolic surgery, when did this come in? This came in 1979 by this gentleman known as, not this guy, but this gentleman here, Professor Scopinaro. So he came out with the idea of metabolic surgery between that segment of 30 to 35. In fact, he's done this procedure even for BMIs between 25 to 30, metabolic procedure. So I met him in Vienna and then again in London just a couple of months back in the World Congress, and he's just the same. I think I've changed, but he's just the same. And so what he actually did was he made this small stomach pouch. He attached a loop of intestine there. But what actually happened was that he just had a segment of about a common limb of about 100 centimeters from the ileocecal junction, which the Indians cannot tolerate. This is good for the Caucasians where they have a non-vegetarian, this kind of diet every day. We can't tolerate this procedure, so it's not really done in our part of the world. But this was the first metabolic procedure which was actually done. The band which was there in the, it came in 1993. So what's happened to the bands? We are actually removing more bands than they are being put in. It's just 1% of all bariatric procedures worldwide as of 2017. I'll just show you a short video of how a band is pulled out, and then you can convert that into another bariatric procedure. So bands, actually this is another patient of sleeve which I did single stage and took out the band. So we are actually taking out more bands than we are putting in. Just 1%, mostly confined to Australia. So this is the gold standard procedure, Roux-en-Y gastric bypass. We have almost 50 to 60% of our own bariatric or metabolic procedures are Roux-en-Y gastric bypass. This was discovered by this man, Professor Whitgrove, in 1994. I'll just show you a short video after this, so I'll explain what the procedure is like. You would have probably heard about this procedure earlier and would have heard from other speakers as well. What we actually do is make a small stomach pouch. This stomach pouch stays. Small stomach pouch. A loop of intestine is attached here. So the food travels from this into the stomach pouch and into the jejunum. That's where, if the food travels into the proximal gut, and that causes the neurohormonal changes to happen. But this requires food to be digested. That's where the bile juices, the pancreatic juices, the stomach juices all come in contact here, and that's where the food starts to get digested. And this is where you have the common limb which goes onto the ileocecal junction. Why it's called Roux-en-Y? Because that's a Y which is made, and that's the Roux-en-Y. What we do in metabolic procedures is somebody who's got a lesser BMI. If this is done with a small stomach pouch, you may have a lot of weight loss. What we do in patients who've got metabolic procedures, lesser BMIs, we make a much larger, lesser stomach pouch, much wider gastric stoma. They can eat well. I mean, they can eat a fish if they wish to, right away 7 days after the procedure. But they'll have an excellent response as far as diabetes goes. So we kind of, so bariatric surgery, when it started, it was 1, 2, 3 procedures. Presently, I do about 10 different types of procedures, depending upon what the patient walks in, what are the problems the patient has, and we can actually titrate or kind of modify the procedure as per what the patient's requirement is. We do put the band across this as well. This is a special kind of band just to ensure that the long-term weight loss is a lot more. So what can happen is, again, some of these patients who walk in, they always mention, is this a reversible procedure? Can you reverse this procedure? So I reversed this procedure to a complete normal anatomy. I can do it without a problem. So there was this guy who walked in, a person who was probably done at about 25, 26 BMI, should not have been done. And he lost enough BMI and he was at 19 and he walked on a wheelchair. And I converted that into an absolutely normal anatomy that can easily be converted. So these are all reversible procedures to that extent. The other thing is, then they always say, do we actually need to reverse? And I'll show you the video, what actually happens. This is a revision Roux-en-Y gastric bypass. So I said I'll show you what can be done in 2017. You would not have seen this, you would not have seen this kind of video, because there are hardly 3 to 5 centers across Delhi, across India, who can probably do these procedures. This is a procedure where a Roux-en-Y gastric bypass has already been done. I have reversed it because the patient has actually put on weight, and I have done a revision of a Roux-en-Y gastric bypass. So those are the intestines. That's where the intestines had been joined. A jejunostomy has been done. Beyond that is the common limb. What happens is once you do these joining together, you have these areas where there could be internal herniations, which was probably left open by the previous surgeon, which was done in 2011. This I have done this year. The patient has done very well after this. The patient started with a weight of about 120, reached 90, again regained weight, became 110. That's a jejunum that almost looks like a stomach. So what happens is, we've reached Mars. We can always beat these procedures. They are nothing. We can beat these procedures. It's a human mind. And a stomach, actually the jejunum becomes almost a diameter of a stomach. That's what actually happens. So you don't need to reverse it. We humans can reverse every procedure. So that's what has happened. We have reversed, the lady had reversed this procedure. I had to resect that part of the enlarged stomach. That is the enlarged stomach which had happened. Reduce the size of the stomach by firing these staplers. These are the staplers. So Medtronic makes these staplers to ensure that we do not have leaks. And thereafter did a redo of the gastrojejunostomy, a smaller gastrojejunostomy, added a more restrictive component just to ensure that the patient starts to lose weight. The patient now is about 98. She's about 3 months post-operative. The second procedure never does as good as the first procedure, but you can revise them. That's what I was trying to show. You can actually convert that into a normal procedure, or you can actually revise them. You would have heard, some of you would have referred patients for bariatric procedure. Most of you would have heard of this common procedure. Worldwide, 51% of all procedures is basically sleeve. Why? I feel the reason is because it's a simple procedure. Most of the people who say we do bariatric procedure just do this and that's enough. It doesn't suffice. Like I said, we do about 8 to 10 different types of procedures. The other thing is simple procedure. When a patient walks in, you tell them you're not going to touch the intestines, you'll only resect a part of the stomach. They're very happy to take the procedure. They say, fine, you're at least not touching the intestines. Let's get this procedure done. Invented by this gentleman here, Professor Michel Garnier. 3 benefits. Decreases the appetite because of the decrease in ghrelin. Small stomach fills up faster, you feel satiety much earlier. Small stomach empties faster. Again the hindgut hypothesis. And then the pylorus works. Highly restrictive procedure. Anything which you take more, patient tries to throw up. Invariably, if you've heard of bariatric procedures where they say we try to throw up, anything we take more, ulti aati hai, vomiting, nausea, vomiting, it's this procedure which causes it. Our numbers of this procedure are less than a Roux-en-Y gastric bypass. I just feel that's the gold standard, that's a much better procedure. But we still do it for younger people, for older people, and somebody who doesn't have comorbidities, we still prefer to do this procedure. This we say is the new kid on the block. This is Dr. Robert Rutledge who came out with this procedure, which is a single anastomosis gastric bypass. Make a small stomach pouch, attach this. So this has been a selling point in Punjab particularly. If you've got patients from Punjab, you know, most of my friends or colleagues, they've been selling this procedure. Have a cooker, you'll still lose weight, get this procedure done. But I just believe that if you're getting a bariatric done, why do you want to have a cooker right away? You don't need to have one. But this is a procedure which does not have a restrictive action. It's only malabsorption. So what happens is, small stomach pouch drains directly into the jejunum, directly goes down. And what you can actually do is, to get the best results, increase this length. Make it 200, make it 250, but then the patients will have protein malnutrition, require multivitamins. So I restrict it to only the super obese. Super obese, I do this, otherwise I don't do it. Again, an interesting case, say revision of a band to one of the, this was a lady who actually had a band for 2008, 2009, lost some weight, regained all the weight, developed diabetes, became a super obese. That's when what we did was we actually took out the band. So you get some pleasure in taking out a band which is 2 lakh rupees, cut it and take it out, and great fun, I did that. So yeah, I took out the band and then converted that into a single anastomosis gastric bypass. She was a super obese and diabetic. For diabetes, a single anastomosis gastric bypass does very well. So like I said, I just wanted to show you some procedures which you probably would not have seen earlier. These are all revisions, not regular procedures. And that's the stomach there. And it forms adhesions around the stomach, this band. And like I said, we are removing more bands than what we are putting in. And so this is a band being removed. So once we've removed the band, then we dissect and make a stomach pouch here. So this is a stomach pouch which we would be making with staplers again. And these are the staplers which are fired to make the stomach pouch. That's the stomach pouch which is being made. This part of the stomach will stay behind. That's the stomach pouch which is being made. And then we'll join a loop of intestine. And you can actually bypass 150, 200, 250 depending on what you want for weight loss or for remission of type 2 diabetes. So that's where these staplers are fired. A small hole or a small gastrotomy is made on the stomach, and then we join a loop of intestine right here. And once we join the loop of intestine, that's where the bypass starts to happen. So this is a procedure which is being done, like I said, widely in Punjab, as not as a revision but as a primary procedure. That's where a gastrojejunostomy is done by firing a stapler. We are doing robotic as well. So I'll confine myself only to robotic bariatric procedures. I'll discuss about robotic GI and others at a later date. We do a lot of robotic procedures that we do at the FORTIS escorts. That's where the robot is. We still don't have the robot at the Vasantkunj facility. We'll probably have it next year. So I go over to the FORTIS escorts. I'm heading that department as well. This is the robot. You would have probably heard some of the speakers speak on robot as well. It's just the finger and the thumb which works. Those are the limbs which the robot has 4 arms. These are the 4 arms which actually dock into the abdomen, and that's how you do the surgery. And I don't need to be there at the head end. The head end, my assistants are there. I'm there sitting down. I can have a cup of coffee and keep operating. So if I've got 4 or 5 surgeries, it becomes easier. But I still believe for just robotic bariatric surgery, it's a hard sell. I can do almost everything laparoscopic. You actually don't need to do it by robotic. It will cost you about 1,25,000 extra for this machine, not for the surgeon here. And yes, if somebody is a super obese, big abdomen, 60, 65 BMI, you need to pull up the patient. These arms are very strong. You can actually pull up the patient with a robot. And that's where you can actually be, it's helpful for super obese. General population, I would not say it's that helpful. Revision procedures again maybe. I'll just show you just a small 1-minute clip of what is that. It gives you a 3D vision, but now we have endovisions as well. We have an endovision at the Vasantkunj facility which is 3D. 3D not just for me, but for the team as well. You just need to wear those big goggles. For people who are wearing specs, you can just clip it on. And but it does have a wristed movements. The robot can go around 360 degree, enhanced vision. Invariably the question asked is, does the robot does the surgery? No, I do the surgery. The robot doesn't do the surgery. And where is the protective mechanism? Invariably the question asked is, if the robot starts to do the procedure itself, it never does. My head actually goes in here. There is an infrared beam which is going across. So I interrupt the infrared beam and I can keep working. As soon as I pull my head back, the robot stops to work. So it's not as if the robot will keep working, because that's the infrared beam which is going across. So that doesn't happen. And but they're coming out with better robots as well. So the patent goes in about a year, and that's where cheaper robots will be coming in. Probably all corporate hospitals will be having one after that. Again, this is a question which is invariably asked by the physicians, by patients. What is the risk of bariatric surgery? The biggest problem that they have is, hum andar jayenge, whether we'll come out of surgery or not. The risk of death. That's the biggest problem that they have, particularly the super obese with comorbidities. What we actually see is that if they have no surgery, they have much higher risk. If they have a surgery, the risk actually goes down. And it's less than any of the bariatric procedures is actually lesser risk than a bypass surgery, a prostate surgery, esophageal resection or a hip replacement. Lesser risk, particularly in high volume centers, in center of excellence, much lesser risk. Safety is there. We ensure there is a safety there. We do a leak test almost always in all patients. Whatever may be the procedures, 8, 10 different procedures, we always do a leak test. Like you would do a puncture test, we do a leak test just to ensure there's no leak, there's no problem there. If required, we do CT scans as well. This is the first day CT scan just to ensure that the dye is actually going down before we start the patient orally. I'll just go through certain myths which are there and the facts. Most people who have metabolic and bariatric surgery regain their weight. That's a question which is asked, and invariably that will be the question that do they regain their weight? 100% will regain weight. Everybody will regain weight. But what is the level of regain of weight? Almost 90% regains some amount of weight, but not substantial enough to require another procedure. 10% will regain substantial amount of weight where they may require another procedure. 90%, even what we've seen, over 1,000 patients that we've done, 10% we've started revising them. And those are the kind of people who would probably not be happy with one drink, will probably be happy with 4 drinks, 5 drinks, will enjoy their sweets. Those are the ones who regain their weight. One thing I always say to all my patients when they walk in, and particularly if they go for a revision surgery, that we as surgeons are doing a GI tract procedure, a gastrointestinal tract procedure to treat what is in between your ears. They've gained weight only because they've got some locha in between their ears. And they regain weight only because that continues to be there. So we do a GI tract procedure to solve this. So if they still continue to have it, they will regain weight. Many bariatric patients become alcoholics after the surgery. That's not true. They enjoy a 30 ml will give you a kick of 120 ml. Small stomach absorbs quickly, gives you a kick much faster. So they have little amounts and they can get very good kicks otherwise. Again, bariatric surgery, bariatric patients have serious health problems caused by vitamin and mineral deficiency. Believe you me, we have a follow-up of 8 years and beyond now. Most of them after 2 years don't require any vitamins. No minerals, nothing. They are practically managing it without that. We do tell them you must take vitamins. Most of us who are sitting here may be vitamin D deficient. So obviously you would suggest that. But by and large, beyond 2 years, most of them don't require it. You should only have a bariatric surgery if you've completed your family, preferably. But if you still want to have a child, we generally advise 18 months. 18 months and thereafter. After bariatric surgery, you won't be able to eat anything that tastes good. That's not true. You can have most of it. Only thing is smaller quantities and frequently. Bariatric surgery is reversible. I've already mentioned it is reversible, and we've reversed quite a few of these. So this is a unique story that I've actually shared with a few of you, and to the others where I've not shared this story, I'll just share it once again. So that's the gentleman who actually came to me somewhere in 2011 or 12, and a diabetic, a BMI of about 42.5, and I did a Roux-en-Y gastric bypass primarily for his diabetes, less for his weight loss. He lost adequate amount of weight, reached a 27, 28 BMI, and then he got his son for a bariatric procedure, worked up his son for a bariatric procedure, found his son to have a serum create of about 11. He was in chronic renal failure, IgA nephropathy. Referred him to a nephrologist for a renal transplant. Every investigation possibly was done, and the only donor was his dad, who had undergone a Roux-en-Y gastric bypass by me. All investigations done for the dad to find out whether he still has a telltale sign of diabetes. Nothing found on him. This is first post-op day after he donated his kidney to his son. So he donated his kidney, had a rejection after 3 weeks. A biopsy was done of the kidney, grafted kidney. Absolutely no macrovascular changes of diabetes. It reverted. He is absolutely fine. His kidney functions are fine. He came back to me 1 year after a renal transplant. I did a bariatric surgery on him. So this is the only duo father and son where I've operated the father, I've operated the son, and father has donated the kidney to his son. So that's the only one in the world. So both are doing very well. The follow-up is still there. They live in Dwarka. And we have a World Obesity Day coming out on 26, which is a Sunday. So we are trying to get this guy's interview. He's in the US. So we are trying to get his interview if possible, so that at least it gives so the general public at large that this is possible.
God bless the next generation, sir.
Very challenging.
Yeah, so another gentleman, he's from Nigeria. So he came to me again in 2011-12. At that time, we had a second generation robot in FORTIS escorts, and he had a rectal cancer, and I did a robotic APR on him, abdominoperineal resection. That's the permanent colostomy that he has here. So I did a robotic APR on him with a permanent end colostomy. 3 years later, he came back to me. All his investigations were normal, everything was normal, but he had regained 30 kgs and he was at that time 130, and he wanted a bariatric procedure. I went through the literature. No gentleman after a cancer surgery had gone for a bariatric procedure. So I checked up the net, I checked up everywhere, couldn't find anything. Finally I said, he was an indication was there, 41 BMI. That's an intraoperative photograph. So I did a bariatric on him. Again, he's done very well. The follow-up is then 3 years after bariatric procedure as well. 6 years after an APR, robotic APR, 3 years after a bariatric, he is doing very well. So again, one of the unique cases where a cancer survivor underwent a bariatric procedure. So these are some of the heaviest patients that we've done. 300 kgs, joined 2 operation theatre, 2 OT tables to actually do this procedure. But, so there was a problem there. She said, I want this off. Now that was because activities of daily living was also an issue for her. You can understand why. And we do not do an abdominoplasty with this procedure because that's where the problem starts to happen. 116 BMI. We worked her up. I did a sleeve on her. Same sitting. After doing the sleeve, a plastic surgeon resected this. So a plastic surgeon, she is 5 feet 1. She had to get up on the OT table. You can see that. and that's how she did. So it's just an anecdotal case. 300 kgs, we combined both procedures together. And she had to actually get up on the table and resect that part. So insurance companies, does the insurance companies now have coverage for bariatric surgery? It's come around, and that's the best part. More than us, I think our Medtronics and the other companies have worked very hard to get that insurance done. So presently we have insurances which are actually recognizing bariatric as a procedure. Only thing is you need to have an insurance of 15 lakhs to a crore, a high premium you need to pay. These are premier Mediclaim policies. You can get a coverage of up to 5 lakhs for all obesity procedures, bariatric or otherwise, all obesity procedures, but you get it by the third year. So first and the second years, you pay the extra premium, third year you get it. So it's there, the coverage has come around with New India, Oriental, National, all of them are now giving coverage. Star always had it. They had it for 2 years now. But now New India and others have also got it. So it's now covered with Mediclaim to that extent. We had the first book which was published on bariatric surgery, and it was released by His Excellency Sri Venkaya Naidu. It's by actually, he had swelling bilateral feet and all symptoms, and diabetic as well. That's where I found out it was a large adrenal tumor. We took out the adrenal, it was actually pressing on the IVC. The IVC emptied, the swelling of the feet disappeared. And then he started running on the treadmill. He doesn't require a bariatric. He's done very well. But this we measured, it was 11.3 kgs. So that's the largest that has been taken out in the world. So we do run these support groups regularly just to ensure that the patients are happy and they interact with post-op patients, and they kind of are more happier. Because even now what happens is that most of the patients who are actually coming in are referred by other patients. And so that's why these support groups are extremely important, and we run them regularly. And I always call them heroes, because they are the ones who underwent these procedures, and they continue to not just, they continue to follow up, and the ones who follow up do a lot better. And more importantly, they continue to send patients to me. Because what I realized was that in my bariatric practice when I started, very difficult to get the first few, then the first 100 or the first few hundred. But after 1,000, the life has become a lot easier for us, for the bariatric surgeons in our practice. What I've realized is that we've reached that critical mass. That critical mass to ensure that 10 patients without a sweat will be referred by these guys. The others you need to work hard to get. But the 10 patients, because once you reach over 1,000, that's what happens. So yeah, they are our heroes, and I always compliment them. And they've lost lots and lots of weight. Some of them, this is a president of Nauru. So this is a person, this is on YouTube as well. So this is a gentleman who actually came to me, and I was told His Excellency President of Nauru is going to come for a surgical procedure. So I said, first I need to find out where Nauru is. I was not aware that that is. So it's a small island in the Pacific Ocean, very near Australia. And tried to do a Google search on it, found out the population is 10,000. That's not even GK1. That's not even one block of GK1. But he was president, so he had all that. So he just came for his diabetic surgery, so operated on him. So lots of patients have been operated. And so before I wind up, I also invite you, if anyone is keen to watch bariatric procedures, on Friday, Saturdays, we have 5 lined up. You're most welcome. You can give me a call. Most welcome to come to the
BMI more than 30 now with comorbidities is a candidate for bariatric surgery. How far is that true, sir?
Yeah, so I showed those that segment of 30 to 35. One can offer metabolic surgery, not bariatric. We'll just call it metabolic. Beyond 35, we'll call it bariatric. But only once you all have actually done all what you need to do to take care of the metabolic syndrome and find that these patients are not responding to medical treatment, and then can be referred for a metabolic procedure.
Due to lipogenicity of the bile, So would you also suggest gallbladder removal at that time or medical therapy only?
So you're very right, rapid weight loss can lead to gallstone formations, but as of recommendations as of 2017, we do an ultrasound on everyone, all patients who undergo a bariatric procedure, anyone with a stone, we always advise that one should get a gallbladder surgery done simultaneously. Number two, if you do not, which are restrictive procedures, we do not suggest or we do not advise bile salts, ursodeoxycholic acids, etc. But for all those where we do,
you do not advise.
No, we do not. That's not the recommendation for restrictive procedures.
Okay.
But for where there are malabsorption, whether Roux-en-Y, partial malabsorption, or one anastomosis gastric bypass, or any other where there is a malabsorptive component, we advise ursodeoxycholic acid 300 milligram twice a day for 6 months.
Right.
That is the recommendations, because if a gallstone is to occur in that early phase, the acute attack is much more severer than a normal individual like one of us. So we always suggest that this should be given for a period of 6 months.
Right. So this in 2015.
Yeah.
How often are you doing that?
So recommended for, there are two indications as of today. One indication is in that segment between 25 to 30 who've tried all their methods. You've suggested medication, you've suggested lifestyle, they do not respond, and they are still not able to lose weight. They do not come in the category of a bariatric procedure. Even extending up to 35 without comorbidities. Young girls who are to get married, who do not want cuts, they are the ones who can be suggested for a balloon. They will lose some weight. They have always the tendency to regain weight because you will take out the balloon from 6 months to 1 year. But that's one indication. The second indication is very high BMIs. Somebody who walks in at 70, 75, multiple comorbidities, maybe respiratory one failure, cannot do a bariatric procedure, give them a balloon, let them lose some weight, and then come for a definitive procedure.
Sir, the stomach folding of the gastric plication recently published in Bariatric Times. So, as comparable to gastric bypass, how true is that?
Yeah. So,
The recent
this is a very
data.
interesting question.
Yeah.
So I'll tell you what plication is first. Just explain. I'll take 30 seconds to explain what plication is and why it came to our part of the world. So in sleeve you saw that we have a full stomach and we fire these staplers to ensure we have a 100 ml stomach and the rest of it is excised and then it is taken out of the body. So if a stomach is 700 ml, we make 100 ml and 600 ml is pulled out. That's sleeve gastrectomy. Now if you hash to the greater curvature has been denuded, it's finally what you would do in sleeve as well. So you have a greater curvature intact but no fat attached to it, and you have a 600 ml stomach. You start to suture like in a plication way just to ensure it keeps going in. So you can keep suturing and making the size smaller, 2 layers, 3 layers. And then what happens is you have got a small stomach sleeve, something similar to this. So we thought we are a poor country, third world country, let's do plication. You don't require staplers, then you don't require Medtronics to sponsor these events. You can just do some suturing. So what happened? So what actually happens is, if you'll understand, all that stomach volume actually is going in. Correct? Because you are suturing and it's all going in.
Yeah.
The patient starts to throw up because the volume actually becomes so little and all the mucosa is actually just going in like a rucksack, everything is inside. So you tend to throw up much earlier. Then what happened, in sleeve what you do is once you fire the staplers and you remove that portion of the stomach, here you have not removed that portion, it's all put in. Where is the blood supply coming from? Only from the lesser curve. There is no blood supply from the other side. You had leaks, which was not expected. So as a result, plication today is done by this one gentleman by the name of Martin Frey in Czech Republic in Prague. He continues to do and he continues to show some excellent results. Paper you already mentioned. but by and large, 99.9% have actually left with it.
Right.
Including our part of the world. So that's why Medtronics are to continue.
Right. So, bone disease, osteopenia, and secondary hyperthyroidism, how common is that?
Yeah, so we do see in
Because of you can't absorb calcium.
yeah, so that generally happens mostly in malabsorptive procedures like one anastomosis, gastric bypass, 60 to 80 grams. We have this kind of food occasionally. Caucasians have it regularly,
Yeah.
and that's why I would err more on the side of doing a lesser bypass than causing all these issues where the patient becomes weak, unable to walk, having protein problems, protein malnutrition and so on. That's why I generally like to avoid an extensive malabsorption, at best for super obese who then can tolerate that, but for people who are, let's say, even 40-50 BMI, they generally like to avoid a massive malabsorption to avoid all these complications. They are genuine issues, particularly with massive malabsorption.
So, how common would that be?
Yeah, so
In your
there
set
are
of patients?
my patients, they don't happen because of the fact that I'm more conservative. But yes, occasionally you would see these problems, particularly if somebody, we know our small intestine is 6 meters, by and large, 4 to 9, average 6 meters. Somebody is to do a 300 centimeter bypass, left with only 300 centimeters, and then you tell the guy to have 80 to 100 grams of proteins. At best he'll take 30-40 grams. You tell him to have a supplement of 2 grams of calcium, he'll probably take 500 milligrams of whatever, and that's where these problems will happen. That's why you require a reversal. They'll come on these wheelchairs there.
Right.
So best to avoid that.
So, my final question: Cemia, because of beta cell hyperplasia, how common is that?
Very common, but dumping, yes. So when you say this, dumping, yes, and dumping is better for all bariatric or metabolic procedures. Dumping is good because as soon as you take these excess carbohydrates, you take these excess sugars, they tend to have this sweating, and it generally tells you stop that, eat less to ensure you don't take more. So it kind of gives you a trigger. But hyperinsulinemia and beta cell overactivity will happen, but not to the extent of having a hyperinsulinemia and blood sugars going down to 20-30. We've not seen in our clinical practice.
Thank you, sir.
So, exercise is paramount, even if you do whatever surgery or whatever procedures. So, this will help in obesity management. Sir, I was very much impressed by your comment that obesity, if you have obesity early in the life, it reduces to 10 years. Compared to diabetes, if it happens in the later part, it reduces your 6 years of life. So obesity is of more importance. So it has to be managed as early as possible. I want to know, sir, baby fat, as you said. So what you are mentioning about infant or a child. If an infant of 1 year of age has extra fat, extra weight, does it matter in his life? Because he is taking only breastfeeding.
So a child who is obese will obviously go off to become a obese adult. But regarding baby fat being more, I would not be able to comment on that part. Yeah, so that I would not be able to comment. But this data is very much there, that anyone who's an obese child has got 50 to 70% chance that they would become obese adults. And what we call as healthy is, the child is a healthy child. That is a myth. And chances of the child becoming a
We call the child after 1 year.
This must be for older children.
My comment.
more adolescents, I think. This is more in
My
adolescents.
comment about ligation and plication was that in ligation or the resection you have removed. In plication you have made a blunt pouch, so it rather adds to your problems.
No, right pouch.
In Roux-en-Y gastric bypass, you said. In sleeve we remove the stomach. So what you're basically saying is, when I do a gastric bypass, in a gastric bypass what happens is that portion of the stomach is still there, but it is not receiving any food. It's still there, it is producing nutrients. and those nutrients are producing gastric juices which are actually going down. So, so I'll answer your question in a way that let's say somebody is to walk in and history is always asked. He has a history or he has a family history of CA stomach. Will I do a Roux-en-Y gastric bypass? No. I will not leave that portion of the stomach, which you call it as a blind pouch, because I cannot access it by endoscopy. Endoscope will not go into that stomach. If somebody is to develop a CA stomach there, that will be a disaster. It will be at a later stage. So I was traveling with this gentleman in one of the conferences where we both were operative faculty, and he's got the highest number of bariatric surgeries in Japan. And during discussion, I just asked him that what is the procedure you do? He said only sleeves. I said, why do you do only sleeves? A diabetic comes in, sleeve. Weight loss, sleeve. I said, why do you do only sleeve? I said, doc, you don't know the high incidence of cancer stomach in Japan. Mediclaim recognizes only sleeve gastrectomy as a procedure and not as a Roux-en-Y gastric bypass, because the incidence is high, so you cannot leave that blank pouch behind. So we always have so one, history is important, two, upper GI endoscopy is important, just to rule out that there is nothing there, and then you can always leave that.
Sir, after some brilliant work that you have shown and your long experience, which is the best surgery to lose weight?
So, so we've actually tabulated our data of 6 years of one anastomosis gastric bypass, sleeves, Roux-en-Y gastric bypass, all same. Weight loss is similar. Diabetic remission is a lot better in Roux-en-Y gastric bypass. So if a person who walks in for type 2 diabetes, it has to be a Roux-en-Y gastric bypass. Somebody who cannot tolerate that very highly restrictive, again a gastric bypass. Somebody who just wants a weight loss, no comorbidities, I'll do a sleeve. Somebody who comes at a super obese, I'll do a one anastomosis gastric bypass. So by and large, these three would occupy almost 95% of my procedure. 5% would be all the other things which I generally do.
Sir, in today's world, if one patient were to walk into a chamber with a BMI of 40, with type 2 diabetes,
Is cure and remission are two different things. I never said I'm going to cure diabetes. Nobody says I'm going to be curing diabetes. Remission, I will give him a realistic figure based on two scoring systems. The first scoring system is A, B, C, D scoring system. The second system is diagram scoring system. How does that work? It works on the age of the patient, BMI of the patient, duration of diabetes, C-peptide levels. Based on that, I can give him a realistic answer. I will give you remission up to 80%. But what I will say, I'll give you 100% improvement in your diabetes. 100% improvement in your diabetes. Without a doubt. Irrespective. Any age. Any BMI. I will give you 100% improvement in your diabetes. If you are taking 4 drugs, you will get to 1 drug. If you are on insulin, you may get to OHAs. I'll give you 100% improvement. Remission, I may give you 76%, 74%, depending upon which category you come in. Cure, I am not giving you any cure. There is no cure for T2D. So this is what my answer is.
Sir, what is the highest BMI that you have operated?
116.
And what is the lowest BMI you have operated?
We have not gone less than 30. 30 as a metabolic we have done. And we have got a decent series between 30 to 35. I have not shown that paper. I just presented at the World Congress in London a paper on between 30 to 35 segment, and we've got excellent results with that. And just for T2DM, not for weight loss, just T2DM. And that segment of 30 to 35, I have done a metabolic procedure. Their BMIs after 3 years of follow-up have just, average BMIs have just come to 26.2. So they've not gone on to this. But the T2D improvement 100%, remission is about 58 to 60%.
So there are two very important comorbidities with type 2 diabetes. One is obstructive sleep apnea syndrome and another is hypertension. In your large experience at FORTIS Vasant, after you have operated your patients, whatever surgery you have done, what percentage of your patients is there remission or improvement in their hypertensive status, the number of medications that they require to control their blood pressure, and in their obstructive sleep apnea syndrome?
So our pulmonologist is right there. So I'll take the liberty of answering this. So OSA, we are routinely, we are not doing the sleep study or apnea, hypoapnea index. We are not calculating as such. I can only give you an improvement 6 weeks post any of the bariatric procedures. Once they've lost weight, they have a significant improvement in their OSA levels. The CPAPs are off. They do not require that CPAPs. Their partners who are sleeping with them can sleep very well without them snoring, and they do extremely well, and long term also they've done very well, and that's what the data also says. Hypertension is directly related with weight loss. So depending upon the amount of weight loss they've had, improvement is there in 100%. Whether they would actually be off medication, one doesn't know.
Sir, I am Dr. R.K. Saxena, who is a leading renal transplant specialist.
You contraindicate doing a bariatric. Then you do say, no, I will not do a bariatric.
So the contraindications are obviously patient unfit for general anesthesia, psychological counseling, substance abuse. All these would be a contraindication where we would refuse surgical procedures. Yeah, so 15 to 70 is what we follow. We have done, the lowest we've done is about 15 years and some months. The data as far as, or the indication so far is 15 to 70 people do go less than 15 or more than 70 as per research protocol only. But substance abuse, psychologically imbalanced are absolute contraindications, and we would not touch them.
Any level of BMI which would you say is a contraindication?
So less than 30 would be contraindication. Higher ones, no contraindications. No, if they are fit for a general anesthesia, they may be fit, like 116 we've done. 116 international patient you can manage. Indian patients after 70 are very unstable. Those are the type of people, either we would keep them for 7, 8 days, 10 days, optimize them with the help of a multidisciplinary team, or if required, we like to put in the balloon, wait for some more time where they've lost some weight, and then offer them a definitive procedure.
Second question was more of an observation. You say that diabetes, of course, cannot be treated or resolved after bariatric surgery. So I was just, as a transplant surgeon, I was keen on seeing that diabetic donor, because obviously his diabetes is not resolved, and this remaining kidney will still remain at risk for diabetic nephropathy. So how ethical it is to take a kidney from such a person for donation?
Absolutely, absolutely. That's a question which I think a nephrologist can answer better, and you know who a nephrologist is. And he presented this in the world, the nephrology conference as well. And so obviously there were the same questions came around, and he said he had the biopsy report with him, which was taken, no microvascular changes, just to suggest that there was nothing there. But yes, in your literature there is a contraindication for diabetics to be giving the kidney. Yes. So like I said, one-off case only.
That large adrenal tumor, what was the histology? They're likely to be
No,
malignant.
this was an adrenal myeloma. Adrenal myeloma.
It wasn't the malignancy.
Yeah, it wasn't.
It wasn't the endocrine.
So I have this.
kidney
Yeah,
tumor
so
either.
I have this lady who's at the moment admitted, and we are going to be discharging her tomorrow. CRF patient, and worked up by Sanjeev again, and BMI 130, and so he said she may be at some time requiring a renal transplant, and let's see, why don't you do a bariatric? So I've just done a bariatric on her, GFR of 10 ml per minute, and she's doing very well. She's going to be discharged tomorrow.
would take precedence, the bariatric or the transplant? I mean, that
Yeah, so
transplant would be a precedence.
Yeah, so we had counseled her for the renal transplant, and probably her age, donor not available, waiting. She's not on dialysis at the moment. She's not on dialysis, but yes. So then finally it was the multidisciplinary team decided, since she's waiting, let's just do a bariatric one.
Dr. Magla has a question.
Wonderful talk, Dr. Wadhawan.
Thank you.
Actually, one of our doctor friends, he underwent sleeve gastrectomy, and 9 months down the line, he developed severe hypercalcemia, 13-14 calcium, and which was not responding to any treatment. Can you explain?
I can't explain by a restrictive procedure. I mean, a restrictive procedure per se should not be able to explain unless he has some other metabolic issue associated. I can always explain with some kind of a malabsorptive procedure and so on. Not with a restrictive procedure per se, I can't explain. I have, like I said, no data published so far for me to actually quote any data, and I think maybe some metabolic issues they already had, or the patient already had, to be, to precipitate that post-surgery.
One possibility was that he took few shots of vitamin D, but that was 9 months.
So 9 months later, having hypercalcemia doesn't seem to be.
All the investigations for hypercalcemia could not be explained, and he was not responding, and his kidney creatinine had risen because of hypercalcemia. That is one part of it. They say that the fat binds the vitamin D, and as the fat keeps on dissolving, this vitamin D is released, and they can get into hypercalcemia. That was one of the explanations.
Hypothesis which was
when they used the net was to explain his hypercalcemia. We were wondering that nothing has happened except that he has undergone this surgery. And we looked at the net, this was the answer. Regarding hypertension, it is said that anybody who is requiring 3-4 drugs for hypertension should undergo polysomnography to rule out sleep apnea. And as you treat sleep apnea, the requirement of drug can come down to 1 or 2. So I think once the sleep apnea is getting better by bariatric surgery, the hypertension also gets better.
Sure.
Dr. Sen has a question. Just a minute.
Please, for diabetes are recommending bariatric surgery as a cure for diabetes. That's number one. Number two, like he said, that if it is there in a patient and there is an erstwhile remission, so be it. But as a primary line cure, it is not recommended.